kill the heat? We're going to get pretty warm this morning.
Yeah, I'll do one.
Be quite loud. So why do we want to focus on the nervous system in the first place? Well, number one, it is the governing system. We'll go right off this slide. What does that mean? And I'm going to make you guys talk whether you want to or not, because we're not going to learn. So if you don't know, I'll just call on you. Why is it the governing system? For obvious reasons. What makes it that?
Descending controls the muscles.
Okay, cool. From a muscular standpoint, what else is nervous system control?
Pulse.
Breathing.
Central processing unit. I'll take that. Yeah, definitely. It is in charge. Okay. So if we're here to assess it in some way, shape, or form, what does that make us? Who's in charge? It's in charge. It is the only thing that knows what is going on in that person's system. It is the only thing. You don't know, the person doesn't know. Only the nervous system knows exactly what's happening. So the assessor in that place is the assistant to the judge, that is the nervous system. We are not the judge, the nervous system is the judge. We have to figure out how to get it to show us what it's doing behind the scenes, so we can start to understand how to feed it some new information so it can operate different. And it's a little bit of a different mindset, because depending on backgrounds and trainings, we try to feel like we have the dominant control over the system. And the only thing that has that control is the system. So we want to start to understand that it's in charge. And we want to start to learn how to speak its language and get its permission to get changed. Couple of paradoxical things about the nervous system. It is simultaneously the most plastic and the most stable. So these are reasons to focus on it. It's also the fastest responding system. Okay? Nothing responds faster than a nervous system. A normal change happens like that. Everything else takes days, weeks, months, years. Okay, so nervous system change happens immediately. People freak out about that because they're like, well, how long will that stay? How many times are you going to do it? The more you do it, the more it stays. It's just like learning any other skill. If you're learning a new language, if you're learning play a musical instrument, you're going to have to practice frequently, and you're going to have to be very engaged in that practice, but nervous system changes are no different than that. Most stable, it doesn't age the way the other systems in the body age. A nervous system at 85 years old can respond the same way it can respond at 5 years old in many cases. All your other systems are going to subscribe to a much steeper biological degeneration over the course of time. So as people age, the nervous system should be targeted more and more and more. And that's not to say it shouldn't be targeted when people are younger, but when they're older, that is your low-hanging fruit to make a change. Okay, so nervous system changes are extremely stable in that place. They're also the most functionally plastic, which means at any given moment, the operating system of that system can be changed. Okay, the central processor unit can be upgraded. What does a change look like? Anyone walking into any of your offices with dysfunction has had a change, haven't they? Okay, so we have to start to think of it like that, and we want to start to understand how that change could have taken place in terms that are more than just physical and biomechanical. Does that mean that that stuff is less relevant? Of course not. What this is a whole separate lens that you can start to overlay with what you do, and you'll see that many parts of it aren't that separate at all, but some parts of it are, and you want to start to see where that fits for you and how you can incorporate it to what you're doing. So that's the basic overview of why we want to focus on that system. Let's talk about how that system can be focused on and what it can do for us when we focus on it. So I want to start to get the idea out to you that your movement capability, and let's talk about what that means, okay? Clarity versus quality. Map clarity, and we'll define maps in a moment, okay? Let's just talk about what quality is and how to be more qualitative, okay? So qualities. Is the range of motion of the person a quality?
I would say that's more objective.
Okay. Is the strength of the person, of the movement, a quality?
Sure.
What about the amount of pain? That's a quality also. How about the speed?
Yeah.
What about the perceived confidence of the movement?
Perceived
All-
confidence, definitely.
Yeah, all quality, and I don't need to be too qualitative versus quantitative, but in this case, Clarity of the map is going to equal the quality of the movement, and then we'll define what the mapping is going to be from there. But what do we want to think of in terms of that? If that person has a strength, a range of motion, a pain deficit, anything that you can think of, a speed deficit, we have to figure out a way to improve the clarity of their mapping in some sort of relevant way to get the quality of that movement to change. That's a governing principle. Anything you need to do that is doing it. And anyone who is helping anyone without drugs or surgery is working neuroplastically, whether you mean to or you don't. You're automatically doing it. It doesn't matter what your training was. If the person is changing without drugs or surgery, you are working neuroplastically. Why don't we just do it on purpose? That's just a basic thought that we want to start to try and do as we move through it. So what affects mapping and what is a map? Let's talk about basic things that maybe are part of mapping. Let's just start with the visual system. Does the visual system have field maps of movement and spatial representation? And we have some, definitely, okay? If you had to guess how many of those there are at any given moment of research, how many different visual field maps do you think there are? 1, 2? Depending on what part of the brain you're looking at, whether you're looking occipital, frontal, parietal, spatial orientation, whatever you're looking at, you're going to see dozens and dozens of overlaid visual field maps by themselves, okay? Vestibular mapping, massive. Another, all different types of overlaid mapping going into the cerebellum, mapping going into the insular cortex, mapping going into the frontal centers, all real-time and integrated. And those are just your exteroception. What about your skin? Skin's another brain. All those receptors are going to communicate afferently with their opposite side cortex, and they're going to give you your dermal mapping. And that can be all different types of things coming through there. Pressure, touch, sensitivity, motor information, you get the ideas on that. So we have all of those coming into mapping. What about your insides, your gut? Anything attached to your vagus nerve. That's a lot, isn't it? Huge amount of mapping going into different areas from there. Respiration maps, do we get the idea? Okay, so all of those are going to come together. What are they made up of? Sensory and motor signals that have been received during the course of your lifetime. Many of them you don't even know you have because they've been in from a very long time. Some of them are as realized 1 second ago. Okay, so it's ongoing and integrated and three-dimensional. It's anatomical and spatial. That's an important point. Meaning that your hand is not just your hand is different if it's here or if it's there. Your ankle is not just your ankle is different if it's there or if it's there. So spatial mapping is a really big issue because sometimes the movement is okay here, but it's not okay there, and it happens again. The same injury happens again because we got a glitch in that spot. Okay, so this defies biomechanics in this case. We have to start to understand that mapping is everywhere. So all of that mapping then can be broken down into, is it exteroceptive? Is it proprioceptive? Is it interoceptive? Let's break those out so we're super clear on those. External reception, visual, vestibular, dermal, goal, anything outside of my body that gives me information coming in. Proprioception, afferent stimulus coming up from the joint by joint system. Simple. And there's more, but we'll leave it at that. Interoception, that's the one that everyone's like, what's that? Okay, interoception is going to be your real-time autonomic homeostasis mapping. Okay, what is the state of the autonomic function? What is the state that's, everything that's keeping you alive? What is the state of the viscera? Am I hungry? Am I tired? Am I thirsty? Am I warm? Am I cold? Do I not like this environment? Hopefully nobody feels that way this morning. Okay, but we get the basic idea of that, okay? And all of those are reporting to different major centers in the brain that integrate that information. So we are looking to get a baseline of what is the potential quality or clarity of those maps and how would that affect the quality of this person's movement. That on a nutshell is what we're trying to understand. So then we have cognitive and emotional interpretations of the signals that come in help form a threat value. Let's unpack that. All of those signals go to form a map, but then I have the interpretive information of those signals, and that's the stuff that we try to leave out of the equation sometimes too. A person with great signals and bad interpretation is going to have threat. And instead of actually understanding, movement in terms of pain, let's start to understand it in terms of threat value. Let's actually make that our word. Okay, so we're looking to decrease the threat value to improve the performance of that movement. And it doesn't matter if that's from a rehab level or an elite performance level. You're always working against threat. That never disappears. Everyone has it. I'm trying to move the needle on my threat value in my downhill racing. Everyone's trying to move we get the idea of what we're trying to do with that. We're always working against threat value. We're always trying to modulate it or inoculate it in some sort of way. So, anything that changed signal or interpretation, can education change interpretation? Okay, so we're changing interpretation this morning. When you have a patient and you tell them something that they believe is not factual in a way that's harmful to them, you're changing their interpretation. Are you potentially changing their movement then? We hope so, absolutely. And so sometimes explaining someone's thoughts and beliefs on their issue is more important to them than actually physically remediating that issue, and that can happen. Because a lot of people have a lot of faulty information at this point that's outdated and flat out wrong. Okay, so we want to make sure that they're up to date on what the real things that are taking place there, because interpretation is really important. Okay, and of course, signaling, well, we're going to go into plenty of areas that can produce aberrant signaling and try to figure out what those are. Speaking of that, what can potentially change signaling? Let's start to just get a working list of things that would have changed signaling in a person's life. This is far from conclusive. But these are key points that we're going to try to understand in history taking. Okay? What can a surgery potentially do to history? Any surgery to signaling. How can a surgery affect signaling? Okay? Pain. Okay. What if we're 6 years past surgery and don't have pain in the surgical area anymore? What else could it be doing? Let's think more neuroplastic changes, things that are harder to quantify.
To maybe shut down at the time of the surgery, will shut down the input back.
Okay, so maybe a version of sensory motor amnesia can start to come out from that area. Everyone laugh, who has heard of glute amnesia?
Oh my God, yes.
Okay, so we've heard of glute amnesia, and I'm always fascinated by neurological kind of paradigms that reach a level of pop culture, but then people don't make the leap in logic of what that could mean. So if glute amnesia is possible, does that mean that any part of your anatomy could experience a sensory motor disconnect? Does the person who has a sensory motor disconnect know they have that?
No.
Absolutely not. No chance, which is why you have to assess their nervous system, not them. Okay? You have to get an understanding of what their thoughts and feelings are. I obviously we agree with that. But at the same time, they don't know what they don't know. And your job is to try and figure that out, especially if it's gone chronic. Because if it's gone chronic, there's a missing link. Okay? And that missing link is not going to be 1 + 1. It's going to be a little bit different. Doesn't make it harder, it's just going to be different. So how else can surgeries affect you besides a disconnect, which is a great option? What else could they do?
Scar.
Yeah,
Okay.
mechanical constriction.
Okay, so from scarring, we think of scar tissue as a mechanical restriction, right? And if it gets bad enough, you do another surgery to remediate the scar tissue, right? Everyone on board with that idea? Okay. That's definitely a very biomechanical understanding of scar tissue. Let's talk about a more neurological understanding of scar tissue. Let's go back to threat and changes in the mapping. Is or isn't that scar neurologically active is the way I like to think of it. And basically what that will mean is, does the nervous system have ongoing noxious stimulus of any sort coming from that area in the body? Noxious stimulus is not automatically nociceptive. Okay? It can be, but any form of aberrant signaling from any receptor in that area is going to start to change mapping quality. The longer it's been like that, the larger the change. Okay, so we have to start to think about, is that area potentially a threat? And one thing that we all have to remember about a nervous system, I should have said this right off the bat, nervous system is predictive. If there's one thing that it is predictive. When people try to model artificial intelligence, they try to build it off of predictability. Because that's how our nervous systems really work. And the nervous system is wired to always predict the worst case scenario. Why? Is it negative? Survival. So are we wired to survive or are we wired to perform?
Survive.
Number one, we are wired to survive. Therefore, when people go, well, why would it do that? That doesn't make any sense. You're trying to understand it from a performance standpoint as if your nervous system shares your agendas. Your nervous system does not share your agenda. It doesn't care about your dreams and your hopes and your performance goals. All it wants to do is live till tomorrow. And if it is cheaper to shut that down now so you can live through tomorrow, you lose that function. If you don't believe me, look up what happens when people have a hemispherical stroke. Why is that system not rehabbing that? It's decided to preserve what works. It's going to keep the good side and you're going to lose the bad side. So if you don't have a constraints-based therapeutic approach that's going to constrain the good side, you're not going to restore anything on the bad side. Okay, and it doesn't matter if you want to, the system is going to make the decision before you, and we always say here, you don't get a memo. Okay, there's no inbox that says, hey, I'm shutting down your left side, it's for the best. Take care. That's not going to happen. Okay, so you have to understand that that is the primal animal that you are dealing with, okay, in there, and it has the rationale of a 2-year-old. It's not going to play your game. You're going to have to figure out how to change its opinion and make it its own idea, okay, and I know I'm speaking slightly esoterically, but it's easier if we kind of ascribe these little traits to it. So, surgery is fairly understood in the idea that anything going on there could be affecting anything. There are no rules. Okay? There are absolutely no rules. It can be a little or a lot. Can a surgical procedure affect a person's interpretation of their issue?
Yes.
Majorly. Could a person have tremendous fear from that procedure? Could a person have tremendous fear that they're going to need it again? Okay, so all of that can also come into it. So it doesn't just have to be signaling, it could also be interpretive. Okay, so just hopefully we're opening minds on that. Vestibular, visual, oral disturbances, specifically. Why? Why them?
The mouth, because there's so much in your homunculus. That's
Okay, so big homuncular representation. Does everyone know what homunculus is? Okay. Big cranial nerve control, right? Lots of brainstem, which we'll talk about a little later, why we care about that brainstem so much, and there's for very good reasons. So major cranial nerve innervation of the oral faculties. What about the relationship between oral and spine? If you have a jaw issue, is it possible that you don't have a neck issue also? Probably not likely, but certainly very possible that you don't, but it's very likely that you do, okay? Very likely if you have a jaw change, you have a spine change, locally or distally, okay? What else? What about braces? I have a better idea. Should an adult move their teeth with Invisalign? I'm sorry if there's any dentists in the room, I don't want to infer, but if you're moving your teeth, are you changing skeletal function? Mechanoreceptive input. Could some of that teeth moving create noxious stimulus or nociceptive input because all your teeth have nerves? Okay, it's kind of a different thought process, but when you're moving your teeth as an adult, you are playing with fire. What about palate expanders? Could they potentially affect tongue mechanics?
Absolutely.
Okay. So what if I had a palate expander, 6 oral surgeries, and I'm talking about me now probably, and braces all before the age of 15? That's a lot of change, isn't it? Okay? And if we're happen to be doing that change while we're getting skeletal and structural change at the same time, it could be quite a primordial soup that you're mixing, and you don't know what's going to come out of that. An adult does it, it's probably even worse, okay, because you're pretty fixated skeletally at that point in time. Not going to start a flame war with this. I don't think something is bad or good. I think we just have to understand whether or not, if that's happening, it could be a factor, and then educate the person as to how that could be factoring. From a history standpoint, person's in with a blown knee, what would it be like to ask what's been going on with you orthodontically this entire time, right? That could be something that's a bullet point in history. Did you have a palate expander? Did you have braces? Where did that fit in your timeline? You had major changes there 6 months before you blew your knee. That could be interesting. Maybe I'm looking at this area then in terms of how I want to change the way your motor or sensory signals are working. So just once again, giving you guys an idea. It's not, certainly not absolute. How does vision affect your movement through space?
Huge.
It's huge.
Okay, it's huge. Definitely huge. What's depth perception? I'll leave that to you. How do we have depth perception?
There's many ways, but two eyes calculate how far away things are from
Thank you.
us.
Two eyes calculate how far away things are there. What's the key word there?
Two.
So as soon as there's two, and by the way, everything in the peripheral has some sort of singular nerve with reciprocal inhibition or some variation of that controlling the function. Everything down the middle works synchronistically. You got two nerves on opposite sides of the brain controlling the same structure. That immediately opens the door for a coordination issue of some sort, okay, if we just break it down to that. So as soon as, and why do we have two in these vital structures? Let's go back to our survival. Why would we have that? What happens if we lose one?
Still survive.
You still got the other. Okay, so we need that wiring in those vital areas, but it does represent a potential issue in terms of the neural control that doesn't take place in the extremity as readily, okay? And I think we know if we lose a peripheral nerve in the extremity, we're gonna lose that function, right? If you lose a central nerve in your pelvic floor, the other half will still work, okay? So you can still survive. If you lose a nerve in your neck, the other half will still work. You could potentially still survive, okay? So anything running down the midline, starting at your palate, going all the way down to your pelvic floor, in terms of physical body and certainly visual and vestibular, gonna have two nerves on opposite sides of the brain controlling it, and some sort of oversight to manage that control. And things can be great there, or things can be a mess there. Okay, so really big area to know if some things are going on. How do you know if someone has something going on with that? They're in trifocals. Right off the bat, they are going to have some sort of palliative that's helping them with their focal distances. Does that mean those are bad eyeglasses? Of course not, but you may want to start to see how that person's ability is to have the motor control of their eyes when they are not wearing those glasses. And for our purposes, we're just interested in how that sets up other neural pathways for movement. If it gets to a certain place, they have direct help for that. So, get a basic idea of that. Previous injuries, learn disuse. Previous injuries, let's just go with the sprained ankle. How many sprained ankles have you had? 9. Okay, I've had 9 sprained ankles. What are we thinking? Well, because I had 4 on one side, 5 on the other, or worse, 9 on the same side. Okay, what are we thinking when we start seeing things like that in history? Chronic ankle sprain.
Repetitive motion.
Repetitive motion. Okay, yeah, definitely. What else? What are we thinking about the signals and interpretation from those areas and anywhere related to the other areas?
There would be a change in the afferent signaling to the brain.
Right. Okay, so if that's going on for a certain period of time, what do we expect to see here? What do we expect to see in this area? Fibrotic tissue?
Decreased sensation.
Decreased sensation? Cool, what else?
Maybe decreased strength and activation and
Okay.
timing.
All here though, right? Where else?
Everywhere.
So, and when I say not just here, I got some anatomy geniuses in the room. You're like, it's gonna get extra, I'm gonna rotate this, it's gonna do that. Cool, that's all true. What is happening to the neural structures that were controlling that area? Are they at the same frequency of firing that they used to be? No. And in a brain, as soon as you decrease frequency of firing in that area, what happens next? Everything else that it also fires with starts receiving decreased frequency of firing. And their nerve cells only need 2 things to survive: fuel and activation. They need fuel and activation. A nerve cell starved of activation dies. Okay, where it downregulates to a place where it no longer has the ability to fire. So what starts to happen is that thing pulls down the brain control above it, and over time, the mapping of what can start to change defies physical, it defies physics, okay? It doesn't have to make biomechanical sense anymore. If it's gone on long enough, or if it was intense enough, and it's pulled down enough hardware up top, you are going to get changes related to those changes in that mapping. And if your mind is allowing that to happen, you will be able to see the problem right in front of you. The problem that we have is we're not thinking on those terms, so we keep it into the box of what is very known. And now but the thing is, we can make all of this very known. You just have to allow yourself to think that way. Learn disuse. What is that? What if all of you just stay in the position you're in for the next 5 years? Is that learn disuse?
Yeah.
Okay, so person's lifestyle, because we are specific creatures that adapt to specific demands. If we are no longer using that, it will start to degenerate from learned disuse. Any of you have any adults that have any changes in balance? How many adults, I mean, when we say change the balance, they're fine. I have yet to meet someone who walks in here who's good, who's perfect, okay? And we have varying degrees of that. It depends on how strict you want to be when you break that out. My question to you is, how many of you would say that the average person you see over the age of 40 has the same type of balance that they would have had when they were 5?
Of course.
Why? Why not? What about the vestibular system is supposed to degenerate in midlife? Is that biological?
No.
That's behavioral. It's behavioral. It is behavioral. So if we have a loss in balance, and I use the vestibular system not because it's the only thing that matters, but because it's easy to make it tangible. Okay, it's the only reason that we're going to use that right now. If we talk about the respiration system, we're going to get a little bit weird. Okay, so if we look at the vestibular system, very simply, if you have lost balance function from age 5 to age 45, what does that mean about that apparatus from a transneural degeneration level? What's that? Threat, sure. So your environment is now automatically more threatening. So does decreased frequency of firing your vestibular system possibly give you knee pain? If we're allowing ourselves to think like this, yes. Okay, if you're allowing yourself to think like that, it absolutely is going to do that. But going back to the inner ear itself and the integration of that signaling, cerebellar, insular, frontal, okay? If it is no longer as good as it used to be, what does it say about those nerve cells that receive that information? Are they as good as they used to be? Okay. So can we just be ridiculous and you'd say, even though it's not clinical, loss of balance as an adult, normal, societally accepted loss of balance is low-grade brain damage. So it's a leap, but you have lost neuron function, and that has far-reaching consequences if you upgrade that. So if we give everyone the same mapping that they arrived here with once they had full functioning movement and there was no deterioration of that map, would that improve their function? Would that improve their brain health? If it works in one direction, it works in the other. And I know that's pushing things a little bit, but I need to just get you to a place where if I make it with a small amount of hyperbole on it, we will start to see that there is bigger things that we can be looking at during this time. We don't want to start to see changes in any of those maps, and if there are changes in those maps, we want to start to see what they could potentially look like if they improve, and we want to see what happens to movement as you plug them in. And that nervous system is plastic, so as soon as you start to stimulate it again, it will start to respond. Accidents, concussions, traumatic events. Car accident. That's double, right? Could be a traumatic event and a trauma, right? To physical trauma. Let's just make a whiplash. Okay, basic whiplash. Okay. Spine, right? What else? What other maps could be affected in whiplash?
That'd be midline cerebral, spine and eyes, you said.
Does force only go in one direction? No. So if you receive a spine trauma from a rapid deceleration of a whiplash, does force only travel in your neck? Does force only travel in one direction?
No.
So can we assume that person, maybe even though they're not diagnosed, might be concussed also? Okay, fair enough. So we're going to assume that if there's a concussion, something happened at least happened to the neck. If there's a whiplash, something at least happened to the brain. Just allow that guilty until proven innocent. Just assume it did instead of assuming it didn't. Okay, number one. Number two, in terms of those areas, is there any limit on the number of mapping structures that can be affected by any number of those events. That means there are no rules. It is individual. Okay? There are no rules. You can have baselines and protocols and all the things that you want to have, but the bottom line is it's individual. Every person is going to have a different experience from any one of those things. And I think that's probably pretty obvious based off of your personal experience with anyone in those spaces. There's no two that are exactly the same, and that's because there's no two mapping overlaps that are exactly the same. And everything matters during that time. The person's personality matters. Their person's prior abilities matter. Okay, I always say that concussions don't do anything; they just exaggerate what's always been there. So whatever was weak on you to begin with will be exploited when you're not okay. Whatever was strong on you from the beginning with will probably be dominant when you're not okay. And that's just going to be what happens, assuming that this one area isn't completely shut down. Ongoing CNS or systemic stressors or diseases. Obviously, if they have metabolic issues, if they have some sort of autoimmune condition, if they just flat out abuse themselves with drugs and alcohol or foods that don't treat their systems well, you're going to be battling that all the time, and they're going to be your group of most erratic responders. It doesn't matter what specifically it is. So the base idea of this was to get an ongoing idea of some of the things that can be most relevant for us this morning. Before we actually start out and begin going through a breakout, Casey, is there anything anyone would like to touch on just from like a basic paradigm level? Everyone's pretty comfortable with that? No questions, no ideas? Okay. Cool. We'll change gears and we'll get started in a moment. I'm just going to introduce a couple of basic pathways so that we can get a working understanding of why something we see in assessment might or may not be relevant. So this is one of the most simple schematics in terms of movement pathways. So everyone just stand up for a second. Put your right ankle out in front of you. Single leg balance test, just kidding. So hold it up and just start to make a circle with your ankle. So how are you doing that?
With a map.
With a map, yes, definitely with a
Many
map.
maps.
Where many maps, okay? Where is the initial, well, let's work from the body up to make it easier, okay? So how is that movement reaching your brain right now? You guys can sit down if you want to keep your right ankle in front so we can start to work this out. How is that movement reaching your brain right now? What's that? Okay, so spinal tracts. What's the first place that senses the movement? Peripheral receptors. Okay, so let's just make it simple. Let's just talk about mechanoreceptors only. So we have mechanoreceptive movement coming up afferently up some sort of spinal tract. From a movement standpoint, that's going to be your spinocerebellar tract. So where's that go? Answers in the name. Goes up the spine and ends in the cerebellum, right? Okay? And it's going to stay ipsilateral at that point. So if it's your right ankle, that unconscious proprioceptive input is going afferently to your cerebellum on the right side, if it's your right ankle. From there, that information is going to be sent back to the left side cortex that originated the movement. More on that later, okay? And to send that signal back downstairs, it's going to go down to the PMRF on the left side, cross the motor neurons, back to that ankle and back up, and that loop is going to be ever present. And we could spend the entire morning just looking at that loop and still have plenty, run out of time. We're going to run out of time just looking at that loop. And that doesn't go into any other complexity because there's so much other cross-firing going on. And that doesn't include a mesencephalon or vestibular system or any of these areas. We don't have a basal ganglia in there right now. Okay, so but just remember the frontal centers, they're going to architect the movement. They're going to send a copy of that movement plan. Okay, they design it, they don't execute it, to that cerebellum. What's the cerebellum do? It's going to integrate all of the information from what you asked for and compare it to all the information coming up of what's actually happening. So it's the great judge, the great integrators. People say the cerebellum receives 40-to-1 inputs to its outputs. So think about that. You're sitting in an organization and 40 people report to you. Are you important? Kind of important, you're kind of a big deal if 40 people report to you, right? And then you get all of that information out and you give one command back and everything happens. Okay, so that cerebellum is a motor boss. Okay, it's absolutely a motor boss. But it needs good plans from the frontal center. So I need a good architect, I need a good surveyor. He's got to send all of that photocopied information there and also send it downstream. And then I'm going to integrate that and I'm going to look at it. So if I'm seeing a change in balance, coordination, accuracy, or timing, I'm thinking cerebellum. If I'm seeing a change in tone, the body's not holding itself in some sort of constraint, I'm thinking that PMRF on the opposite side of the movement, okay? And we can get into spine and a bunch of other stuff, but I just want you to kind of allow yourself to think in those loops, just between those places for now, and we'll move into it a little bit further as we go, and we can stop for a minute and pull anything up and kind of go over these as we get a breakdown of that. One other major thing that I want to make sure that we have in our minds as we go. So, let's backtrack that. We're back in that left cortex, and we're going to do our right side ankle movement, okay? Movement plan starts in the frontal center. Where does it go down to next? Goes down to the brain stem on that side, the PMRF on that side. At that point, it's going to cross. Let's just make, I need to do this, or let's make it really big. I need to do something like this, okay? Lots happening here. I need to be able to do a upper and lower extremity figure 8 while not moving my other side. How much of that demand crosses to the right side of my body? 50%, 80%, 90%, no percent. How much of the voluntary movement pathway actually goes to the area that's being moved?
I remember this as a trick question.
It is a trick question, but it's
The
not.
answer is you said 20%, but I would think it would be everything that would cross over. But
Wouldn't you think the voluntary movement is the shiny object? That's the thing that we're all supposed to focus on, right? Okay, that's the shiny object. But it's not. That 90% of that initial neural drive to do the movement stays ipsilateral in the form of reflexive tone. What is reflexive tone? It is the constraints that are going on behind the scenes that make everything that isn't supposed to be moving not move, so that the one thing that you want to move at that moment can move. Okay? Is that core strength?
no.
The way people understand core strength? No. Can you do more ab work and build that back into the equation? No. If that's missing, does core strengthening even, is it a waste, is it even worth your time? Absolutely not. So, if anything, that improves the ability of that 90% that stays ipsilateral, makes your core or your reflexive tone or your ability to hold yourself appropriately in some sort of dynamic postural alignment while you're doing that movement. That makes it possible. So if that's the case, and I know that most of that is being managed by my PMRF, that's your below your mesencephalum, that's your pons and medullary area, the reticular formation on the outside of it. If that's managing that, if I upgrade the signals or the sensory and motor information going into that area, did I just make you stronger? Okay.
Yes.
And we can start to go into what those things can be, but can an accessory nerve guide improve reflexive tone then? Yes. Can a tongue exercise improve reflexive tone? Hell yes. Okay, these are things that you want to start to allow into it, and you don't even necessarily have to go to the point where I'm going to do that kind of work if you're not interested in it. What you can do is go, that person's holding their tongue and their jaw really weird while they're trying to execute that. That's not right. Because you see it every day. And you go, they're just weird. Okay? They're not weird. That's maladaptive plasticity right in front of you. Okay? And they're trying to summate. So when they can't get signaling through that area, they're going to do that. They're going to do that. You see it all the time. I know you do. You're going to see this. You're going to see some sort of engram of something that doesn't belong in there. And when you see that, that's your first clue that something's up with this loop. Even if you haven't done a breakout, just watch them in their movement. In the training room, during a lift, it makes no difference. You're going to start to see these things right in front of you. Go, that's interesting. You weren't doing that before. What did I change? Okay? You're doing that. You're already doing amazing. Okay?
It's like back in medical school when in the dark ages with the dinosaurs when I was there, everyone talks about that motor pathway crossing, and I had zero training in this reflexive tone back then.
Yeah.
It's just, it blows my mind. It always does what I'm saying, it just blows my mind.
Okay, yeah, so I think what ends up
Because
happening.
the pathway crosses.
The pathway crosses.
Yeah.
Yes, it does.
Yeah.
Where does it cross?
Do it.
Okay, so if it crosses in the medulla, where are you? You're in the brainstem.
Right, but then that ipsilateral reflexive tone, it just wasn't, like, I'm
Yeah.
old, but it just wasn't taught at
Yeah.
all. Yeah.
Yeah, so
Still not.
would you say it still isn't?
It's still not. I'm at the medical schools. They get very little of this stuff.
Yeah, so here's the thing. When people are trying to build a robot, there's some really smart people that can, like, just Google Boston Dynamics if you want to see some crazy stuff, okay? So they can make robots do some, like, really scary things, like stuff that you would only have seen in the Predator movies. It's a robot. Now that thing can flip and be a gymnast and kill you, okay? You know, it's pretty amazing. Do you know what the hardest part about building the robot is for the geniuses that do this?
The reflexive tone of it.
Yeah, it's putting in all of the constraints, coding in all of the constraints that we have automatically, innately in our movement. It is not designing the movement. A fourth grader in a robotics class right now can make an arm move. What they can't do is make the damn thing stand up while the arm is moving. Okay? That's the special part of what's happening. And I'm not trying to make you believe that this whole morning is about reflexive tone. I'm just hopefully adding in something that you've never thought about before. In terms of when this is not working here, what's happening everywhere else that's supposed to be managing that? And should I even be doing voluntary movement work in that affected area with this person today? That's the thought process that I want to start to engender into, because if you have something that can change the constraints, you're gonna be fascinated by the fact that on the backside that issue is no longer as strong as it just was. And if you do need to go there and work in that area, it's going to be received completely differently now. And maybe that's a week, maybe it's 2 weeks, maybe it's 5 minutes before that you employ that work. If you see it's there, it's something that you have to address first. Because if that's missing, the voluntary movement pathway will never work. Okay? You'll always hit threat, you'll always hit nociceptive activity there. So hopefully that kind of opens the door a little bit. So we got a base idea of what cerebellum's doing, we got a base idea of the role of the PMRF. Everyone cool with that? Let's get started. If anyone needs a bathroom or wants to take a quick break, now would be the time.